That was a great video. You guys were busy yesterday. Yeah, we should probably applaud ourselves, huh? It's a great way to start with an HIT talk. Just a little housekeeping, just again to reiterate about the importance of the evaluations. We do have evaluation police up at the top of the exits, so you won't be able to escape. The other important point, we will be videotaping this session, including the Q&A, so we want everyone to be aware of that. And we'll be saving questions to the end, but not to worry, but there'll be plenty of time to interact with our panel. And of course, since we are always concerned about the digital divide, we discovered we had one here yesterday with the Twitter questions. So we will again try to do the Twitter question at the end. Will be on the screen. So this is round 2 to cross the divide at the Twitter level. And today we're going to be talking about HIT, and as many of you yesterday noted, people were bringing up questions already yesterday that were relevant to what we're going to discuss today. And the questions are incredibly varied because HIT is a huge area describing an enormous amount of different technologies, including electronic health records and all of the components associated with that, support systems, decision-making systems, documentation, but it includes personal health records and management of chronic diseases with text messaging, telemonitoring. We're talking about population health tools, which are large chronic disease registries within systems, more telemedicine. So there's a lot to cover in this area. And today we have a distinguished panel of experts, all in different areas of HIT, who will talk to us about their experiences, their viewpoints, and also give us an opportunity to interact and get some of those burning questions addressed that we've been discussing off and on since yesterday. We have here Dr. David Blumenthal, who is the Chief Health Information and Innovation Officer at Partners Healthcare and was the former National Coordinator of Health Information Technology at the U.S. Department of Health and Human Services. And in that role, he was instrumental in leading adoption and implementation of meaningful HIT use. And he'll be discussing his views and getting us a sense of where are we now after these efforts that are still ongoing. Next to David is Dr. Steve Atlas, who is the Director of Practice-Based Research and Quality Improvement Network at MGH. And in this role, he does a lot of work in population-based, patient-centered care, putting all the pieces together at a systems level. And he'll be talking about his experiences with that. And next to Dr. Steve Atlas is Dr. Kamal Jethwani, who's the Corporate Manager of Research and Innovation at the Center for Connected Health at Partners Healthcare. And in this role, he does a million things, as I've come to know, but he does a lot of interesting work with delivery models, social media, text messaging, telemedicine, and we're currently working closely with him. And the full bios, just as yesterday, are in the books. So let's get started, since time is always moving along quickly. Dave, since you had such a significant role in sort of and spearheading the direction of adoption and meaningful use, can you give us a little thumbnail sketch so that everyone gets a sense of the stages and the idea behind the adoption and meaningful use efforts?
Sure, Lenny. Well, thank you. It's great to be here and great to be participating in this work, which before I left to go to Washington, I was much more involved in as director of the institute that Lenny and Joe work in at Mass General. I went to Washington to run a program called High Tech. It was created as part of the much maligned stimulus legislation. I like to say that the stimulus legislation created at least one job, and that was mine. And the purpose of High Tech was to create a nationwide, interoperable, private and secure electronic health information system, a modest task. I think ever since we as a human race first use a stone to crack a piece of bone to get at the marrow, we've been fascinated with technology. Whatever the technology was, at whatever stage, whether it was the first wheel or the first arrow or the first telephone, And when we talk about health information technology, we similarly tend to focus on the technology. And now it's the CPU and the wire or the iPad or the iPhone. But when you peel away the magic of the interfaces and the plastic cases and all that, this is really about information. It's really about summoning information for a purpose, and in this case, the purpose is the care of patients or research or education. And I like to do the armchair experiment to get a sense for the importance of information in the care of patients. The armchair experiment is you go up to a patient care floor, you're going to see a patient in a particular room, you go to the patient's record. It could be in the old paper form, or it could be in the form of an electronic record. And you push on the button or you open the chart, and there's nothing there. Nothing. No patient name, no age, no demographic data, no diagnostic data, no laboratory data, no x-ray data. What do? What can you do for that patient? You're virtually paralyzed. You're incompetent as a health professional. Of course, you can try to replicate it at all, but you can't replicate it. That information is in some ways the most precious resource that clinicians have in the care of their patients. It's in some ways, it's not a scarce resource, but it's a very difficult resource to mobilize. And the whole point of health information technology is to mobilize that information and to make it available when you need it. It's the circulatory system or the nervous system of healthcare, if you will, of one of our precious resources, in some ways the lifeblood of medicine. And what I often say is that if carrier pigeons were the best way to provide information at the right place at the right time for healthcare, I would be advocating for carrier pigeons. But right now, I think we've got something better. It's called electronics, and we're trying to mobilize electronics to their highest and best use for the care of patients. This is a tool. It doesn't do anything by itself. A computer never operated on a patient. It never dispensed an antibiotic. But it is a marvelous tool to help people get to the right care at the right place and execute properly. Realizing that, the Congress created a program to try to bring the US healthcare system out of the dark information ages. Basically, for most of the United States, we continued to record and manage and store information in 2009, pretty much the same way Hippocrates did 2,400 years ago. We'd replaced quill and parchment with paper and pen, but we were still doing it pretty much the same way. There was no way to run a health system. The Congress recognized that, and they created the HITECH Act to try to do something about it. The HITECH Act put aside up to $30 billion in additional Medicare and Medicaid payments for physicians and other providers of care who adopted and meaningfully used certified electronic health records. The key to getting that extra funding was, if you were a physician or a hospital or a nurse practitioner or any other eligible provider, was to meaningfully use the electronic health record. The concept of meaningful use was, at the point that I became head of ONC, still undefined. It had no, if you had gone to Google and searched on meaningful use prior to April or February of 2009, you would have gotten pretty much no hits because it was a concept without any meaning. The first job we had at the Office of the National Coordinator was to fill in the meaning behind that. What is meaningful use of information technology, health information technology? It's the meaningful use of information, the meaningful use of that precious asset. It sets a floor under what we expect health providers to maintain as far as information about the people they care for. That floor had never been existed before. There had been no standards, no requirements. We all, as physicians, nurses, other health professionals, learn about how to take notes about patients and how to record and communicate about them, but there is no standard. There is no minimum requirement for what recording of information should contain. The meaningful use of electronic health records, for the first time in the history of medicine, anywhere in the world really, created a floor under what the record should contain. We could go on for ages about this, but that's what interested me most about it as a healthcare policymaker and a health services researcher. It's why I got interested in that particular program, not because of the technology, I'm not a technologist, but it's because of the opportunity to create a level set for information and its management and its maintenance by the entire US healthcare system. Right now, things are going reasonably well with this program. About 120,000 providers have met the criteria for meaningful use. The federal government has paid over $7 billion in incentive payments to hospitals, physicians, other providers. Half of all US hospitals have become meaningful users. That's way more than I expected at this point in time. The meaningful use as a concept has pretty much been accepted in parlance in the US provider community. A second stage of meaningful use has been divided into stages so that the federal government can take providers along on an escalating curve of requirements. The second stage was promulgated about 2 months ago. It was pretty widely accepted without a lot of controversy, but it's a lot more demanding. And I just want to say a couple of things for this audience about the high-tech program and its meaning for disparities and for equity. It is, there are very specific and more generous payments for Medicaid providers under the meaningful use provisions. If you're a Medicaid provider, for the first year, you can get a payment of about $20,000, not for being a meaningful user, but just for purchasing, acquiring, or upgrading your technology on the way to being a meaningful user. So there's a recognition that there's a catch-up that's needed for people who are qualifying for Medicaid. The actual payments that you can receive as a meaningful user under Medicaid are more generous than under Medicare, $64,000 over a 5-year period compared to $44,000. So that there's a more generous sort of flying start and then a more generous set of payments. Once you qualify or seek to qualify for payments, you have to meet the same standards. Those states can create slightly different standards for the Medicaid population because the Medicaid population includes children and pregnant women who are not part of the Medicare population. The other thing that people aren't widely aware of, but to be a meaningful user of electronic health records, you have to record race, ethnicity, and preferred language in electronic form on patients. So while we talk a lot about the availability of data, the meaningful use requirement is making it happen in real time and is going to, I think, revolutionize our ability to study disparities and to track the availability and use of care for people of different racial and ethnic backgrounds. This change snuck through without a lot of attention. If we tried to do it in an upfront fashion, I think there would have been a lot of clamor, but it just was part of this incentive program, and it's now spreading everywhere. The other thing I guess I would point out, the other thing I'd point out is that the implementation of the high-tech program did not consist entirely of meaningful use and its payments. There was also about $2 billion set aside for the use of the national coordinator to try to lay the infrastructure to support meaningful use, to help providers become meaningful users, to help with the exchange of information among providers. And we put about $700 million into a program of regional extension centers. Those regional extension centers were meant to provide sort of shoulder-to-shoulder, elbow-to-elbow support for providers. We knew up front that we couldn't do what we wanted for everyone, so we prioritized small primary care practices serving underserved populations, community health centers, and critical access hospitals. So those have been right up from the beginning a prioritized group of providers for the meaningful use assistance programs. What do we know about adoption at this point? As of 2011, the National Ambulatory Medical Care Survey, which is used to track the availability of and use of electronic health records by the Center for Disease Control, it's a source of truth for us on the extent of dissemination of electronic health records, showed that 74% of community health center physicians were using an electronic health record, compared to 70% of academic health center physicians and 50% of physicians in physician-owned practices. So it's clear that at least for this, that part of the safety net, the community health center was successfully moving into the new world of information technology. There was also in the 2011 survey no difference among provider adoption by gender, race, or ethnicity of provider. So to the extent that providers of color are serving populations of color, we know that there is no, at this point, difference in the availability of this technology for those populations as compared to majority populations. All that is not to say that there isn't a danger of a digital divide. On the consumer side, I do think we have to be aware of the differences in availability of technology and the differences in likely use of technology. I don't think we know a lot about that yet. And the consumer-facing side of information technology, which is one of the most exciting parts of this development, I think is pretty much unexplored territory and one that we have to pay a lot of attention to. But on the whole, I think that as we look back on this program and this effort 20 years from now, I think up to this point, we can say that we are on the right track. There's no evidence that we are creating more of a digital divide than existed before. And I think we are laying the groundwork for the modernization of medical practice and the creation of a foundation of information that can support the best quality and most efficient medical services. So I'll stop there with 2 minutes left to go.
Thanks, David. I have a question for you on that to follow up. You know, there was a very thoughtful approach to including, safety net providers, Medicaid, high Medicaid providers, et cetera, some extra bonus money to get them going. Some people have, in some quarters, worried still about this because if you're starting so behind, the extra, $20,000 or $40,000 in terms of implementation, would that really make a difference? And if the community health centers are only at 74, 75%, how would you get them to 100%, or the safety net hospitals if they're starting so far behind?
Well, they're actually ahead. So 74% is very high compared to the average physician. Only about 40% of physicians, 35% of physicians nationally use a basic electronic health record. So the 74%, I think, puts community health centers way ahead of the curve. And the reason they're ahead of the curve is at least in part because we know that the most powerful predictor of adoption is group size. Being part of a group is really important to giving physicians and nurses and other health professionals the technical support and the confidence they need to make the leap into the electronic era. Now, will we get to 100%? I think we will, because the incentives for continuing to collect the meaningful use funds remain. And they've gotten their first few payments, but they've still got other payments coming down the line. We also know that, frankly, and this was a subject of a New York Times article just this week, we know that though physicians and other health professionals complain about the slowdown that is associated with electronic health records, they are very powerful methods of improving your billing efficiency. So there are revenue incentives independent of meaningful use to having electronic health records. As a policymaker, I confess to mixed feelings about that, but if that's what's needed in order to get us over this hump and to get us into the modern era electronically in healthcare, I think I'm willing to pay that short-term cost.
Another question that actually came up yesterday in our Q&A, one of the concerns has been, and that you're part of developing this complex architecture, is the sort of siloing of data and getting it to communicate, and that there's a whole piece that you haven't chatted yet about in terms of health information exchanges and all of that. Can you talk about that with a light on equity and the sharing of data across providers' systems?
Mm-hmm. So the sharing of information is an incredibly interesting, complex project. When you think about creating a nationwide, fluid system for exchanging information, where information really follows patients wherever the patients are and is available in its entirety for any healthcare experience, that is an enormously intimidating proposition. I think it's a whole lot harder than sending someone to the moon or doing the Human Genome Project. And why is that? It's because the problem isn't technology, it's the human beings involved. Getting the humans to want to do that is the biggest challenge we have. It's a humanware, not a software problem. And the reason is that we live in these incredibly competitive, fractionated healthcare markets that are rampant with suspicion and distrust among the providers of care. And getting them to sit down and collaborate, to take on the costs and the burdens and the technical burdens of exchanging health information, there's just nothing in it for them. So we have to create the environment in which there's some value to exchange before exchange will occur. Now, there is, for disadvantaged populations, an additional burden, and that is that ultimately what will make this work is when providers see an economic advantage to exchanging health information. And that means that people whose care is paid for are always going to be more interesting to share information about than people whose care is not paid for. The relatively modest pennies and dollars needed to support a health information exchange capability are going to be a lot easier to kind of sneak out of the bills of paying patients than uninsured patients, and of well-paying patients than poorly paying patients. So I see, in that sense, a potential disadvantage for the poor and uninsured. On the other hand, counterbalancing that is the fact that governments have the ability to enforce requirements around sharing for publicly insured patients. So I wouldn't be surprised if in some states Medicaid is a leading enforcer of exchange as a requirement for care. Now, Medicaid's such a poor payer that how they're going to get people to do that, I think, is not quite clear, but there have been a number of states that have talked about how do we use our leverage on the Medicaid side to force providers to share data, at least about Medicaid patients. So this is an open chapter. I don't think we know how this is going to unfold. I know in 20 years from now, we're going to have pretty ample exchange of health information, but right now, we don't. And I would just also point out that I don't think there's a country in the world that has really nailed this.
Steve, just to follow up, I know you'll present in a second, but in terms of David's comments, from within a large system like Partners, what has been sort of your experience with the siloing and getting different parts to talk to each other? I mean, it's part of the project, large projects that you do, is getting all these pieces to come together. What has been your experience?
I think, so I work in a primary care network affiliated with Mass General Hospital. And we're blessed through Partners with an incredibly sophisticated IT infrastructure. But many of our patients seek care outside of our institution within other partners' institutions, or even in institutions that aren't affiliated with our network. And so the example of exchange of information is a great one where we can capture about 80% of the data on our patients, but we're missing the other 20%. Where do we get that? How we don't have an infrastructure in place in Massachusetts yet to do that. Even within our institution, how we get data from across town. So someone goes to a hospital across town from ours, and as part of our network, the way they code information, the way it's available is slightly different. So there's a lot of real challenges, even when you have the data, to make it meaningful in terms of the provider being able to access it in a uniform way.
And I know in our work, this is a big challenge in terms of doing research and trying to follow patients longitudinally and all of this when you're missing this kind of data if you're trying to document and follow along on racial, ethnic, language differences. So the data part is still a challenge, a significant challenge. You want to tell us about your presentation?
Sure. So, so as David was talking about the issues of, and I actually am going to present some slides, so I don't know if they can be brought up onto the screen.
I think you just have to keep advancing.
Have to click.
Mm-hmm.
Oops,
there you go.
There, good. As said, I'm a practicing primary care physician at Massachusetts General Hospital, and I direct our practice-based research network, which also includes a key component of doing information management measurements, as well as quality improvement efforts within our network. And for us, we really have taken the issue of sort of how do we use the information that IT brings with a specific end in place, and sort of how do we use it to improve care. Whoops.
Oh.
That's cute. That's not mine. But whoever it is. There we go. So specifically, our goal is how do we use information technology to redesign how we deliver care in our network. And for those who do primary care in other settings, this is the same issue that you all are facing. So just like many of you, we face a current state where the quality of care, you can argue, is mediocre, it's unsafe, it's inequitable, it's very focused on my needs and not necessarily the patient's. And we know, particularly in Boston, that it's extraordinarily costly. So we've been focused on how health IT can really transform how we deliver care. There's other aspects than IT. There's also, we're spending a lot of time about how do we redesign team-based care to move away from necessarily the doctor as having to do everything. It has also made us take a step back in terms of looking back at sort of who's our population that we're involved with. It's not necessarily just people who come and see me on a regular basis. It's people who may have less continuous care within our system, but may still identify themselves as getting care here. And there's also the sense of, again, taking what does the patient need? A patient-centered approach, scheduling systems that focus not on what's easiest for me or for our care delivery system, but for the patient and a whole patient outlook, sort of not necessarily focusing on one disease, but all of the issues that a patient has. And then specifically for this, it's sort of how do we then do all that and yet integrate this knowledge about disparities to become part of what we routinely do, as opposed to necessarily being sort of a sidelight that we sort of do on the side, but it's not part of our main infrastructure. So just to set the stage sort of where I come from, our network involves about 200,000 patients. We have about 200 primary care doctors, many of them, including myself, because we're affiliated with Harvard, are part-time providers. We have 17 practices, and they're relatively heterogeneous. We have 4 recognized community health centers. We have 8 community-based practices and 5 hospital-based practices. So very different practice settings, as well as very different patients who come to these places. We've used data over time to look at sort of where our patients live, and this is eastern Massachusetts, and the darkness of the color is the number of patients who we provide care for within different communities in eastern Massachusetts. And the blue little dots are sort of where our healthcare centers are used. This information is used for a lot of different purposes, some of which are as simple as marketing, about sort of who are we providing care to, and how do we marshal our resources within the communities that we serve. We've also spent a lot of time collecting data and understanding how patients in our network relate to the providers that they see. So we've done a lot of work as base level in terms of our IT, is to say any patient within our network being able to link them or connect them with a specific provider. And is this my patient? Is this David's patient? Is this a patient who may not necessarily come to see me very often, but comes to see one of my nurse practitioners or urgent care centers within our network? And what we see, and this is looking at cancer screening rates in our network over a number of years, what you can see in this data is that there's a big difference in terms of the outcomes, the care measures that patients get based on terms of how they are connected with the caregivers. So individuals who are less connected generally score, these are the bars on the right side, lower on breast, cervical, colorectal cancer screening than patients who have more established relationships with our providers. And we know in terms of looking at these individuals that these are patients who are less likely to be white, less likely to speak English, and have lower education levels. A lot of these different challenges that make the way we deliver care less efficient for them. And you can also see across the data that we do better on certain things than others. So we use this information to sort of direct where are we going to focus. And as you can see in this data, on many aspects, we do a lot better on breast and cervical in our network over time than colorectal. And that became sort of a focus for us to say, well, what was going on at this time? This was back in 2005. And we started to delve into the data. And this is looking again now at the same type of information back across racial categories. So for mammography, pap smears, and colorectal cancer screening, what you can see is that, at least by ethnicity, there wasn't too much difference in terms of rates of screening for breast and cervical cancer. On the other hand, there was considerable disparities in our success in terms of getting colorectal cancer screening up to date for our patients. And notably, our rates for Hispanic patients in that network were 50% below those for white patients. And this led to some additional work that specifically for us, over half of our Latino patients are cared for within one of our health centers in Chelsea, Massachusetts, which is about 3 miles north of here, across the harbor. And this is a community that's low income, ethnically diverse. It's a gateway community for many immigrants. And this health center recognized that this was a real disparity in care for them. And then they sought to use this information to try to change that. And what they specifically developed was a multilingual patient navigator program where they hired a Spanish-English navigator and used several interpreters who already existed for other languages within the health center and trained them in terms of how to address disparities. And they actually did a randomized trial where they looked at, in effect, early versus late navigation. And we used IT to identify these patients and to send patients letters in their language identifying that they were overdue for colorectal cancer screening. And then using IT, the navigators were able to identify patients who had visits, meet them, and they had sessions, as well as call them at home if they weren't following up with visits. And then we assessed outcomes over 1 year and showed a dramatic increase in the rate of completion of colorectal cancer screening within this one health center. And specifically, they were very interested in not just getting the standard, which can be sometimes this home stool test, but they actually wanted to set the gold standard. Could they also do it for colonoscopy, which is a much more intensive type of treatment and showed that most of the screening actually involved getting the colonoscopy done. They've continued to have this program in place and have shown that over time, the disparity that they had noted in terms of lower rates of colorectal cancer screening in their population, which is the blue, has over the last 5 years actually closed so that there's almost no disparity. And we've used this as a model to say, can we use this type of navigation system so this works in one place? How can we potentially expand it farther? So we talked about it's addressing the needs of half of our Latino patients, but what about the other half that are cared for in other networks? So, so that's where health IT can come in, and it provides the ability to focus on new models of delivery. We can take a population-based approach, and can we then take things like this Navigator program and broaden its use to be able to work in a broader range of practices where the percentages of disadvantaged patients may be different, the language and cultural issues may be different. So how can we use this to redesign systems to decrease disparities? And our focus has been how do we integrate these systems for addressing disadvantaged patients into our broader efforts to use population-based IT to screen our entire population and to not have the Navigator programs, which we currently have sort of existing as sort of a sidelight. How do we integrate them into usual care and to make it part of the connections that patients have with their doctors in their practices and not necessarily a standalone piece? And that's sort of where we are now, and we can talk about sort of that a little bit more.
Mm-hmm. So this is a great example of how you know, on the population level of a system, you were able to integrate the IT and a real well-known intervention, the use of navigators to really, change and eliminate that disparity. Just for everyone out who's listening, sort of behind the curtain, under the hood kind of thing, what kinds of things do you need in place to be able to harness that kind of information? Obviously, you have to put the data in, but who else is involved, and how many of the pieces of the system are involved to do something like that?
So within our network, there's several pieces that are key. One is, as I said, you have to know who your patients are, and you have to know where they're getting care. And if you want to use IT to work outside of a patient visit, so a patient of mine who hasn't seen me in a year, how can you find that patient and then link them to me? So we spend a lot of time developing the IT infrastructure behind the scenes that actually connect the patients. Then the other is how do you bring the disparate pieces of data together into one place? And how do you present it to individuals in a way that is not just data, but is actionable, so that I can then look at my list of patients who are overdue for breast cancer screening, and then actually start a process. What do I know about this patient, because I may know them very well, to initiate the process. And then you need to have a system that then tracks whatever that process is. Do I start with a letter? Do I send them to a secretary to make a phone call? Do I involve a patient navigator? And then how do we track the system for completion of tests so that there's a feedback loop to that information? And each of these separate steps is an IT system in and of itself that has to be brought together into one new platform, which we've developed within our network and is now being expanded to partners over the last several years.
That's exactly what was my next question. For those who may be listening to what sounds like a wonderful, multi-leveled process, how long did it take to put this all together in terms of, getting the data, putting the data, bringing it all together, analyzing data, finding a disparity, picking one to work on? Give us a sense of that.
A long time. So David was talking a lot about the need for just getting health IT into practices, but just having a box on your desk doesn't work very well if the patient, EHRs are designed very much for one-on-one, face-to-face encounters. But if the patient doesn't show up, it's not going to be an efficient mechanism to manage that patient. So several have tried to use EHRs as a way to manage populations, but we've actually taken a different approach where we have different EHRs even within our own system and are using a separate platform to draw information from the EHR, but to really design a system where it's independent, where someone can I look at my panel typically on a Friday afternoon, where I can go through my list of patients and deal with them sort of independent of my EHR. So just having the box is necessary, but in many cases it's not sufficient. And this process for us has evolved over really a 2 to 3 year period and is still an ongoing one to disseminate what we've put in place.
Mm-hmm. One of the things, David, that Steve is really highlighting is coming back, the power that you can harness from EHR. One of the things, a theme that came up yesterday where people were, and I know you've heard this before, so we want to tap into your thoughts about this, the multiplicity of EHRs and how they're sort of configured and can they talk and be useful in being able to do what, an example of what Dr. Atlas was presenting. Within systems, there may be multiple EHRs. So what are your thoughts about that?
So we are human, and we like to do things our own way. And when it comes to your electronic health record, whether you're me or Dr. Atlas or Dr. López, you want your record configured for you because you like to see things a certain way and you like to have certain kind of information. And that's wonderful, and it's terrible at the same time. And I learned very quickly when I got to Washington, people said to me, we're going to have all these records, and they're not going to talk to each other. Why don't you just tell everyone to buy the same record? And I thought that was a good way to get fired. Because there is just no way that Dr. Atlas and Dr. López would tolerate my telling them exactly what record they should buy. So we use the market, and what we hope is that by letting people choose the best record for them, that there will be a kind of market test of the success of those records, and that good records will emerge, and that then when we know which ones the good ones are, we have to assure that those good ones can communicate. Now, in fact, quietly, the federal government's been laying the groundwork for interoperability. That's the technical term for what we've been describing. The technical term is interoperability, which is allowing, that's a condition where records are capable of communicating with one another. The key thing for that is that they speak a common language. If one record speaks Greek and the other speaks Chinese, it's going to be hard. You can create a translation between them, but there's always going to be imprecision. So you want them all speaking English. And the federal government is now making it a requirement that all the records speak English. Now, the interesting thing is that we didn't have a language to require. That is, we didn't have a computerese for medicine that if we had told everyone to speak it, it would have gotten us where we wanted. We had bits and pieces, but not a complete Webster's dictionary. And so the federal government is creating that Webster's dictionary sort of piece by piece. And the last set of standards that were promulgated about 8 weeks ago took a giant step forward. And you will begin to see the benefits of that in about 2 to 3 years when the next stage of meaningful use becomes a requirement. But the real benefits will probably be the following stage when we have really gotten that much more sophisticated. So I would say that by the middle to the end of this decade, interoperability will be a fact of life, and it will allow multiple records to talk to one another if, and this is a big if the humans want them to.
The human factor.
The human factor.
Yes. One of the themes that's been coming up, and not only here but in our conversation, is about the digital divide and how to engage the patients. And Steve presented one where you're using the system at a very high level to identify people and then have a different type of engagement. And now, Kamal, you can talk about the digital divide and engaging folks through all the different methods that there are out there to sort of engage their disease management or other kinds of things.
Yeah, sure. So I think, David said a few minutes back, there is no digital divide. So I think my job here is done. But, but since I have slides, I'll show them to you. And I think the one other point I really enjoyed, especially in Steve's presentation, was that we're talking about care redesign. We're talking about redesigning primary care. And I think that's where the real opportunity here is. Health IT is a tool. It's an enabler. It can let you do a lot of things that you can't do otherwise, or you can't do otherwise efficiently. And so how you use it is where the magic is. It's not what you use. However, when you're speaking about equity, you really want to be careful about what you use, because there could be a chance that the way you use technology could, in fact, worsen equity problems. So what I'm going to do is, I'm just going to do a really quick overview of what current disparities are and what the technology use is in different vulnerable populations. How can technology help? And then spend a little bit more time on just getting you guys really excited about what technology can do and where we can go with this. So, cultural disparities, we've thought about this in a lot of different ways, and I think a lot of my thinking has been helped by Dr. Betancourt and Lenny here. So thinking about knowledge and motivation and what the disparities there are. There's difference in health literacy, cultural factors, and then especially when you come to access barriers, we think about language, geographic barriers, and economic barriers. So, reiterating the point that there may not be that much difference in technology use, when you look at the technology use by whites, black adults, and Hispanic English speakers, you'll really see cell phone ownership, for example, is really in the high 80s or 90s. Everyone has a cell phone. Simple cell phones is what we're talking about, feature phones. Smartphone ownership, obviously, it's low across the board. But again, if you look at the bar graphs there, there's not much difference between each of these different racial groups. SMS, which is texting, is really high, and it sort of goes hand in hand with cell phone ownership. And then towards the end, I have mobile internet use and photo sharing, which are lower, but again, you start seeing a little bit more disparity in those sections. The next slide I have is socioeconomic disparities. And the two graphs here divide populations by income and by education. And across the board, you'll see, obviously, wireless and internet use is high, but it's a linear relationship between how much you earn, and it's a linear relationship with how educated you are. And you'll start seeing some level of disparity, but even then, even at the lowest level of your income, there's still about a 50% internet use, which is pretty high compared to what it was about 5 years back. And we critically see $75,000 income annually is the tipping point. Above $75,000, we see very flat use. The use is very good. Very high cell phone usage, very high smartphone penetration, very high internet use. And below $75,000, there's a little bit more disparity. Geographic disparities. Again, when you divide people by urban, suburban, and rural, you'll still see cell phone ownership really up there, and there not being too much of a difference there. What's interesting also is that although internet use and broadband use is low in rural populations, they're still pretty high up there when you think about photo and video sharing, because I think this population has really taken it up as a way to communicate and connect with other people, because I think there's the population density is lower. Also, what's very interesting is about language barriers are important here, because language proficiency is one of the most important predictors of whether you're going to be an internet user or not. So even within blacks and Hispanics, English speakers do way better in terms of internet use than others. The other very interesting point that we've seen in the last 3 or 4 years is about 17 to 18% minority groups use internet solely on their mobile phone. They don't have broadband, but they depend completely on their smartphone for internet access, compared to only 10% white. Which is interesting. It's a growing trend. We've seen that trend go up from 10% 2 years back to about 18% this year, which sort of talks about how different groups are trying to get internet use and bridging the access barriers in different unique ways. And there's opportunity there with smartphone penetration increasing every year. So how can technology help? Now, we've used, I think, as I've sort of walked through, I think cell phone usage and cell phone ownership is really high, and we've sort of wanted to tap that market and really see how can you use cell phones, or more specifically texting creatively, to reach these populations. We all know, if you guys have tried phone calls, it's a very difficult way to reach people. People don't pick up, you never reach them, voicemails, it's a messy system. Compared to that, text messaging, we've seen way more success. We've used them for what we call support system messages, like appointment reminders, discharge summaries, other things like that. And then we've also used them a little bit more for more core behavioral interventions, like medication adherence, support, education, motivation. We've used it creatively. We've sent out text now almost in 4 different languages, and we see the same receptivity across the board, irrespective of what language we use. And then the other way to think about, the other way we've used technology, especially in this field, is the use of telemedicine. So one example that jumps up, and I'm going to speak about that in a minute, is that immigrant groups especially use photo and video sharing technologies on the internet way more than we would expect. And this is mainly because that's one way that they keep in touch with folks back home. And that's an opportunity because they're already so used to using these video technologies like Skype that now when you start using them for clinical care or for telemedicine, it really opens up a big box where these people are comfortable using it. You're crossing a really big access issue here where maybe culturally or otherwise they feel that they can't come and access care, but now they can do it from home using Skype, using a system they've been used to already. So there's a huge opportunity there. The other opportunity, when you think about the same example of using Skype, is of cultural competency. We don't have as many providers who are trained in being culturally appropriate with these populations, or even in the minority linguistic groups. And now this is a way to expand the capability of these providers who are now going to be able to reach these patients and provide more efficient care to these patients. With that next step, so just a single minute, I promise, about what we do at the center. The main goal really is to make healthcare delivery more efficient. We try to integrate care into the day-to-day lives of our patients and really focus on patient self-care and focus on practice efficiency using health IT. This is an example. Oh my God, I'm horrible at this, sorry. This is an example of a remote monitoring program that we've used at the center. What we basically do is every patient who has heart failure goes back home with a bunch of devices. It's a weight scale, a blood pressure cuff, a pulse ox, and they're supposed to upload their data every day in the morning. Pretty simple. If they don't upload their data, they get a call from us. This is a panel of telemonitoring nurses who are watching their data. If they've uploaded their data and they're fine, nothing happens. They don't see anything. If they're out of range, they get another call. We confirm their data, and we sort of implement an action plan. It's a 4-month program after which patients sort of graduate outside the program, and we take the devices back. And we've seen that just being part of this program reduces readmissions by 50%. There's an opportunity here, especially when you're thinking about groups of people, especially with battling chronic disease and who have access issues and other issues, being from minority groups or whatever, there's an opportunity here where they're taking care of themselves. They're sitting at home, they're uploading their data, and they're taking care of themselves and really learning self-efficacy on their own and improving their own healthcare and improving their own quality of care. We've seen this program work across language groups. We've seen this program work across ethnic groups, and it works really well either way. The other thing I wanted to point out was texting. We've used it for a variety of purposes. One of the earliest ways we used it, which was really simple, was to remind people to apply sunscreen. A problem with sunscreen is that you don't really remember to apply it, and even if we remind you every day, it's not like you're going to really do it. The incentive is not as great as it is maybe with insulin use. But even then, when we sent people daily messages, we saw that the intervention group, as you can see on the graph, maintained their adherence to about 80%, 70 to 80%. For sunscreen adherence, that's really, really high. And you can see the control group went down to almost 20%, which I think is typical, is what you see. The one thing we learned was people get used to these texts every day. If I text you every morning at 9 o'clock, and you know that the text is going to say the same thing, you're going to stop opening my text. So what we did was we started putting the weather forecast. Now, remember, this was 7 years back, so you didn't have weather apps on your phone. So we sent them the weather forecast, and that made them open the message and then read our plug about wearing the sunscreen. We've now used these same tricks in other things. We've used it with pregnant women to encourage prenatal care. We've seen better appointment adherence. We've seen better satisfaction with their care. We've seen better practice loyalty, which it seems is really important for primary care practices. We've used it for diabetes education, and now most recently, Lenny and I have been working on a program, I'm going to move ahead, to use texting as a way to improve activity levels in patients who have diabetes. And so the way we've built this program is we look at a lot of different things about a patient. We segment them into whether they really want to lose their weight or not. What's the readiness to change? What their daily step count is as measured by a really inexpensive device. It's a pedometer that goes onto their shoe. It's $20. And it wirelessly measures their activity and uploads it automatically to our database, and where they're located or where their practice is. And we take all these different parameters and put it in our engine, which sort of personalizes messages for these people who get it every morning saying, you walked 45 minutes yesterday, which is 75% of your goal. You need to do better. And in the evening, they get messages that tell them, or that educate them about how they can get better and that motivate them. And that's where we really use the readiness to change aspect of it. So if someone's in what we call pre-contemplation, which means that they haven't even thought about changing their behavior, we send them messages like, how about buying running shoes? Just think about that. Versus someone who's in action, who's really pumping it every day, we give them tricks like, it's going to rain outside tomorrow. We've seen your activity drop before when it rains, so here are tricks to get it indoors. Why don't you run around the dining table or whatever, run on the block for twice or thrice and you'll be done. Or running 5 minutes is equal to 10 minutes of walking. So if you don't have time today, just run for 5 minutes and you'll be fine. And what this really does is it really sort of hones in on what the patient is feeling at that particular moment and talks to him at that point, which I think is a great advantage of having technology and using it creatively. So again, with all these examples, I just want to emphasize the technology is out there and it's been out there for long. It's how you use it, what needs you're solving is where the magic is. So here's an example of the messages. They're low cost, they're tailored to these patients, they're interactive, so patients can actually reply back. We store the reply and we put it in the analytic engine. So we know that if we've quizzed you on something and you've answered it wrong, you need to get that piece of information again. And so we'll send it back to you in the next few weeks. And then we'll quiz you again till we know for sure that you've got the point. And it's intuitive because now it starts looking at your step count, it starts looking at your profile, and starts changing these messages based on you. So you and I could start on the same message on day 1, but by day 60, we're getting very different messages. And we've used these programs in a lot of ways. When we think about redesigning primary care, these things will start making sense because the one outcome measure that we're looking at is A1C. And if you start controlling these A1C levels and bringing them down, there's automatically, performance grows up, pay for performance measures, and all of those things will kick in. But as of today, in a fee-for-service environment, patient loyalty is something that we're looking at, and that we've seen going up pretty well. Patients feel cared for. They feel like they're being supported. A lot of times, patients will go back to the clinic and be like, the message you sent me yesterday was really good, and the physician knows nothing about it, obviously. But we word them in a way that it seems like it's coming from the practice so that they feel more connected to the practice. So one last example that I'm going to use is we piloted a system using FaceTime on Apple and Skype, a combination of that with college students with depression. And we found that they were way more likely to access these services on Skype rather than going to a counselor's office. We redesigned this program for Chinese Americans who speak Mandarin only and who have been screened positive for depression. They usually come back to the hospital about 18 to 20% times only, even though they have culturally competent physicians. One of the problems is appointments. It takes about 6 to 7 months to get appointments with the physician you want. And culturally, they feel like there's a big cultural barrier in whether you want to go to someone for help with depression or not, because in Asian cultures we don't see it as something you need help with. You shouldn't seek help for it. We saw these numbers go up dramatically when we started doing the same consults on Skype, and the quality of care remained the same, and the access went way up dramatically. All these systems are direct to patient, but also meet HIPAA guidelines, so it's all safe and secure. Yep. Thank you.
Great, Kamal. I think as we get ready for some questions from the audience, this is your chance to bring all those burning questions to the panel. I also want to highlight, Kamal, you didn't state this part, and many of the folks may be interested in this. We took all the text messaging and translated them into Spanish, so they were also culturally appropriate. So we are doing a randomized control trial that includes Spanish speakers who have diabetes to increase activity. So and we're having great uptake. So in terms of enrollment. So I think there's a lot of potential here for looking at other languages and other cultures and other issues associated with that. But this has been an amazing, whirlwind tour of all of these sort of aspects at different levels of IT. Questions from the audience? Yes, we have one right over here.
I have a question regarding the use of the smartphones and the texting. And we've heard from our patients, and it's anecdotal, we haven't done a survey of it, that there's a lot of sharing of phones. Like, I might have the phone one day, and then my sister needs it tomorrow. And how do you kind of control for that factor if you're sending these personalized messages, or that the phone will be with the person at that time, or they may run out of minutes, and they may not have access to phone at that time. So that's one question regarding that intervention. And the other intervention that you had talked about in terms of monitoring the heart failure patients at home, in our organization, we used a similar type of a program with some of our patients, and what they found is that sometimes the data that gets into the blood pressure, it's their neighbors. They'll say, "Oh yeah, come over and you can test your blood pressure on my machine." And and this one patient was kind of selling the opportunity. And so how do you kind of control for that? It's a great idea, but what really goes on at home?
So I'll answer the second question first. We set parameters. I mean, of course, if they're 120 by 80 and the neighbor's 120 by 80, we'll never know, but it doesn't matter. But usually you can see the numbers and find out whether it's the same person or not. Now we have very intelligent systems. For example, weight scales. Weight scales can now identify whether it's the same weight or not based on daily trends. You know that you can't gain like 10 pounds, 20 pounds, 30 pounds. So the weight scale automatically puts those weights in different profiles and sends us the right profile only. So a lot of times we allow up to 3 people using the same weight scale in the family, and we tell them 2 more people can use it, and the weight scale does the work automatically. So we know we get the data only that's relevant to us. Going back to your question about phone sharing, so that's one reason actually that we worked a lot on how to word these messages. So none of these messages were talked about diabetes directly. They were very appropriate in the way they motivated people. Also, I think What we've seen by experience is that when the whole family, if they're sharing a phone, they will know what these messages, who these messages are for. And they usually will go back home and be like, oh, there was a message for you. Also, the other thing we've done is we've habituated patients, so they get the message every day, 9 a.m. and 6 p.m. So even if the phone's not with them, when the phone comes back to them, they'll know that they should have received a message and they will go and check it. We're running the clinical trial now, and I'm the PI, so I'm doing a lot of the day-to-day stuff, which is not always exciting. But what we've seen is, patients will call us at 1 o'clock in the afternoon and be like, I didn't get my step count in the morning. It means they're waiting for it. And then we'll troubleshoot and we'll find out that they either got it and someone else checked it and they can't find it in the list of messages or whatever. But what that tells us is that they wait for it. And so at that point, it doesn't really matter if they're sharing or not. Do you want to add anything, Lenny?
No, I think that's really important. And because of all of the issues, we can't even use the word diabetes.
Yes.
So exactly. It's very, we had to really work on these messages. But we had over 900 plus messages, to develop. So it was quite a project.
Yes.
There was another question here.
Yeah, this question's for Dr. Atlas. Who runs your population reports? Do you have to put in a data request? Or is it something you're available on your desktop that you're able to do yourself? And if you do have to have another department run your data requests, how long does it take?
We work with our lab of computer science to, in effect, pull the data that we need from existing systems. So one of the comments that David made about sort of interoperability, so we spend a tremendous amount of time. So just finding out the mammograms at the 5 different institutions in our network, they're all called different things. So there's a tremendous amount of work just in collecting the data that will be dramatically lowered if we standardize the process. So there's a lot of data that exists, and we have a group that sort of brings it together into a data set that is then usable for the doctor. So when they open their, it's a web page, where you'll in effect have your list of people that have information about who the individual is, what they're overdue for, when they're next going to see you. In effect, all the information that you as a clinician would need to be able to make whatever the decision, whatever the clinical decision is, whether it's cancer screening or whether the patient has diabetes and needs to have an A1C drawn, all in that environment. And we often use now natural language processing software to, in effect, bring in information from all the EHRs into that note for you to be able to then use that information, in effect, to make the decision at that moment about what you wish to do for that specific patient. Is that what you're getting at?
No, these are not reports that are instantaneous. It takes a period of time to get all the information in one place and then present it to you by that web page.
So these are near live systems. So depending on the data structure, they're updated. So we query, for instance, our radiology files for mammogram completion on a daily basis. So that if I send a patient a letter, or if I have the system send the patient a letter to you to get a mammogram done, and then the letter says in your native language sort of how to do that if you wish to, and you call and then make an appointment, we will then catch that a day later, and then the system will be uploaded where, in effect, that patient will disappear from the record until the due date. And then if they get it done, the system knows it, and if they don't get it done, the person comes right back. So there's a lot of different moving pieces to it, but it's a semi-live system. These aren't static lists. We did that initially, and that's good for one-time screening. But for doing this on a continuous basis, it's really, you have to be moving towards real-time data assessment about who the patient is, where they're being cared for, scheduled tests, completed tests. There's a lot of information that you need, and clinicians know those different pieces. And the job of the IT is to bring it all together in the moment for you to make a decision.
Thank you.
There were a few other hands up. There's one actually right there.
Thank you. Thanks for your presentations. They were very informative. My question is for Dr. Blumenthal. I am from Cincinnati, and you know, we're a beacon community, we're a regional extension center community, and an AF4Q community, and we have a practical problem that you might be able to address. So we're trying to train all of the primary care provider staff in our community to collect race, ethnicity, and language data. And the practices that are affiliated with health systems are typically using the OMB categories, because all of our health systems are using the OMB categories. We've adopted that as a standard for our community. With the independent practices, while they are able to collect REL data, they are not necessarily using the OMB configuration. And so this has become a barrier to training those practices. And I was just wondering if you have any practical kinds of solutions to that problem.
So first, I should let those of you in the audience who don't know what some of the accomplishments of Cincinnati are. They have been one of the leaders nationally in creating effective health information exchange, and have been way ahead of actually the federal government and many other places, and that's why they've attracted federal funding and foundation funding to support that work. So Cincinnati's to be applauded. This is a problem that many communities would like to have, because it shows that you've already got an understanding of who's doing what electronically. My first response is that as part of the last version of the Secretary of Health and Human Services adopted regulations for standards for racial, ethnic, and language data, OMB definitions will now be standard. So in the future, to be a meaningful user and receive meaningful use payments, you will have to be using OMB categories. So if that solves your problem will be solved in 2014 when the new standards become effective. In the short term, I have no solution for you except education.
Thank you.
Sure.
There was another hand over here. Mm-hmm.
Thank you. It was all great. Humanware. You said something about humanware, and then Dr. Atlas said something about interconnectivity, and then, you know, Dr. Jethwani, I didn't want to mash your name, said interoperability as well. So how do we bring together the three things? Because obviously we have a gap where not everybody is technologically savvy or there at the moment, and then we have the human part that needs to come in and sort of fill that gap. I think we love our apparatuses, and they're very great, but we still have to go back to the humanware. How do we solve, well, not solve it, but how do we sort of start breaking down that barrier?
So there are a couple of, this is sort of a classic problem of behavior change, and one of the first things you need to do is create the capability for things to happen, and this is the technical part of it. So you need a community infrastructure that consists of records, electronic health systems, information systems that define things the same way, so that when the data is entered, it's entered with the same definitions in the same ways, same units of measurement, all those important things. Then you need to create the literal synapses, the connections between the different sites in which data is stored. Now someday, all this data will be in the cloud, And that'll make it a lot easier to create these connections because you won't be connecting CPUs that are located under people's desks, which is a whole lot harder. But until we have that, it is still possible to take that data out of CPUs and move it from one place to another using common definitions. It's not hard to do. People who hack into your machines know how to do this easily, and they're motivated to do it. And the next thing we need to do once we've got those technical capabilities is to create the motivation to allow that, to get providers to allow people to query their data, which a lot of providers are reluctant to do, and or to actively share and participate in sharing. So how do we create that motivation? That's the hardest nut to crack in social change. We have to make it easy to share data, so that's the technical side. But then we also have to create the economic and social peer pressure that will together make it common practice. I do think that systems of care will lead the way because they will come in and solve those technical problems and then create the peer environment where sharing is expected. And so at Partners system or one of the other big systems in the country, that peer and institutional pressure is going to be created over the next decade, I think, if payment reform proceeds and if accountability for patient welfare really becomes internalized. There's another whole way of approaching this which holds some promise over the next 20 to 30 years, but I don't think holds immediate promise, and that is to put the patient in the driver's seat and make the patient the kind of steward of their health information and essentially enable or permit their providers to get access to information that's stored under their control in the cloud. And that's the bet that Microsoft and Google made when they created personally controlled health records. They made the bet too early, and it's not worked because there aren't enough patients interested in doing that, and the barriers are still too high. There is hope that that people under the age of 40 will kind of fall into this just kind of naturally. We'll have to see. One of the problems we have is the people who use most healthcare services right now are not people under 40. And so, on the other hand, people of my age and older who do use a lot of healthcare generally have children or relatives who may be under 40. So that could be a counterbalancing factor. So we'll have to see it. But this is not going to be easy. That's why I think it makes the moonshot look easy. It's lining up millions of people in collaborative networks. And this is a team sport. It's not something you can be the Tom Brady of health information exchange, but if you got no teammates, you're not going to win the Super Bowl. So it's really a team sport.
We have time for another. Yeah, there's another question here.
Thank you, panelists. Dr. Blumenthal, you talked about the requirements, meaningful use requirements to capture race, ethnicity, and language data, and also increasing stages in the program. Can you speak to perhaps future requirements for providers and hospitals to use that data to monitor disparities and drive toward equity, please?
Well, that's a great question, and the way the meaningful use program works is that it is unfolding in stages. We were just at the beginning of the second stage. We've outlined the requirements for the second stage, but we haven't put them into effect yet. They go into effect in 2014. That stage is beginning to push toward better use of the record, not just the recording of information. So, for example, the kind of ability to survey your patients or collect information on a category of patients is a requirement for stage 2 of meaningful use. So what Steve has labored so hard to do, using an electronic record that wasn't constructed to do that, will no longer be necessary once stage 2 certified electronic health records become available, because they will have to be able to assemble panels of patients by diagnosis. Now, once you build in that capability, then you can begin to sort patients by race and ethnicity, or as a category, or by diagnosis, and cross-reference to race and ethnicity. And then you have the information base to do what you're talking about, which is to do directed interventions. Now, you can do that now, but you have to do your own programming. It's not built into the record. My hope, and I can't predict what will happen because this is a matter of the regulatory process, and lots of people have their finger in that process, the Congress, the interest groups, and so on. But the regulatory process, I hope, will start in stage 3 of meaningful use and beyond, 2016, 2017, to say you have to begin addressing, through some combination of registries and decision support, race and ethnicity differences. So I can imagine that being part of meaningful use. I can easily imagine that being part of meaningful use. It won't start with a kind of blanket address all race and ethnicity differences and address all of them, but it might say pick 2 or 3 as the first step in that direction. So I think that you're on target in terms of where this is going. Now, I would also point out that the Meaningful Use program is a voluntary program. If you don't want the money or you're willing to be penalized, you don't have to cooperate. But the penalties for hospitals especially are pretty steep. Now, if you can't tell what the political process can do. This part of the law could be repealed. All kinds of things can happen. But I think we're on course to get where you're heading.
In the last, I think we only have a few last closing moments. Kamal, one of the areas that people talk about, and David was talking about the less than 40, there's a dividing line of 40-ish. In IT use, there's a lot of interest in social media. And I know that there is literature out on, for example, type 1 diabetics, who tend to be younger and using social media. Has the center done anything with social media, or your thoughts about social media?
Yeah, we've launched about 3 projects with using social media in the last about 6 months. One interesting fact is that if you just divide it on racial lines or ethnic groups, 7 out of 10 minority groups actually use some form of social media compared to 6 out of 10 people who are white. And of course, when you break it down by age, obviously you'll see below 40 engaging much better. Twitter is interesting though, because it seems like the older generation has picked it up way more than college kids. And so the way we use Twitter is different from the way we use Facebook. But we've mainly used social media for wellness. Anything that has where you need daily connection with the patient in order to change behaviors or lifestyle modifications. I think social media and texting are really good candidates for that. We've used Facebook for weight loss in adolescents. And we've used Facebook for tracking teenagers who have asthma and keeping them on track and helping them track it and connect that data back to their physicians. And we've seen very good uptake in terms of follow-up rates. We have about 80% follow-up rates compared to 18 to 20% in the clinic, because teenagers don't like coming back to the hospital. And we've seen very good rates of increased activity in teenagers who are competing on Facebook for incentives and other things. So it's how you construct the program, but we've seen some pretty good success.
Another promising area.
Yes.
From the panel, we've heard a lot today, and you know, I'm hearing a lot of hope from David, and it seems that the digital divide is disappearing. There might be nothing to cross in the next time we sit together, but we'll stay hopeful. From Steve, we really got to see, you know, what population management in conjunction with well-known disparity reduction methods can really do in terms of chronic disease management. And Kamal has showed us that, you know, on the patient level, you can really do some amazing things with all of this technology, regardless of the 40 age sort of divide in there. So there's lots of options for making a difference in disparities. Just some housekeeping things. Don't forget the evaluation. The evaluation police will be looking for you upstairs while you get your coffee and refreshments in the foyer area. Let's not forget about Twitter. And the Twitter question's up on the slide behind me here. And let's give a thanks to our panel.